Good day. I'm Dr.K Gireesh, physician, neurophysician, and neurosurgeon. This is the RNA series number 57. RNA is nothing but the random questions in neurology and neurosurgery with answers by Dr. K Gireesh. This is to benefit the practitioners of neuroscience and medical field for a lifelong learning and also for the public awareness. In this series number 57, what I'm addressing is Sunderland classification of nerve injury, which is also applicable to the facial nerve injury as well. The Sunderland classification is a 5-degree system describing the severity of the peripheral nerve injury, including the facial nerve. It expands upon the Seddon's classification. Sunderland refers to Sydney Sunderland, an Australian neurologist and anatomist. The grade 1 is neuropraxia. Pathology, there's a local myelin damage with axons are intact. Facial nerve example, temporary facial weakness, like in the mild Bell's palsy. Features no Valerian degeneration, or there is a contraction block. Recovery is complete within days to weeks. Grade 2 is axontomesis. Pathology is axons are getting disrupted, connective tissue is intact, and there is a Valerian degeneration distal to the lesion. Facial nerve, you get moderate weakness or paralysis. Recovery, a good regeneration occurs at 1 to 3 mm per day. Grade 3 is the endoneural damage. That is the axon plus the endoneurium. The effect is regenerative axons may misdirect. Facial nerve, you get synkinesis, abnormal movements, incomplete recovery, and the recovery is usually partial, often imperfect. Grade 4 is the perineural damage. The pathology is axon plus endoneurium plus perineurium are disrupted. The effect is severe scarring and no proper direction for the regeneration. And the facial nerve, there is a severe paralysis. Recovery, poor without surgery rather. Grade 5 is neurotmesis. Pathology is a complete nerve transaction. In the facial nerve, you get a total paralysis and loss of all functions, motor, taste, lacrimation depending on the level. And there is no spontaneous recovery and requires surgical repair, nerve graft or anastomosis. So, clinical relevance of this classification, especially in facial nerve injuries, it helps in the prognosis and decision making, guides conservative versus surgical management, also the timing of intervention. Early explains the complications like synkinesis and aberrant reinnervation. Now, the key clinical aspect is the more the connective tissue layers are damaged, the worse is the recovery. That's very important. That's indeed the features of the Sunderland's, the classification of peripheral nerve injury, and it's applicable to the facial nerve injury too. Thank you. Thank you very much.